Hello, I'm Dr. John Cruz, and today I'm going to be talking about ADHD and PTSD. I guess on some level these are both unfortunately somewhat controversial diagnoses. And I will start as usual with the take-home message. So ADHD and PTSD are associated with each other. So if you have ADHD, you're more likely than the general population to also have or develop PTSD. If you have PTSD, you're more likely than the general PTSD or non-PTSD population to have ADHD. And to add to the confusion, these conditions share a number of symptoms in common. So sorting them out is helpful, imperative, one would say, for treating people successfully. And the last part of the take-home message is that currently we know more about how ADHD may contribute to PTSD than the reverse situation about how PTSD may contribute to ADHD. So I'm going to start out with PTSD. It's one of our few conditions in the DSM, in the official category of mental health entities, conditions, diseases that require an external traumatic event or any event. So that isn't part of the definition. An individual must experience a serious, either life-saving or not life-saving, life-threatening, or serious injury or maiming, or including things like torture. And the experience part includes not just experiencing it directly. You could be a witness to it, you could be a audience hearing about it, or you could even sort of be a third party watching it repeatedly over and over again, although the official DSM definition is that only qualifies if it's part of your job forcing you to do that. So people who work for Facebook or Google, whose job is to look at possibly sexual violence or other horrible things that need to be removed from the site, can experience, by full definition of our current terms, trauma. That trauma qualifies as a PTSD evoking experience. So in addition to the trauma, there's 4 other categories that someone has to have symptoms in. These symptoms have to cause distress and dysfunction for at least a month, and in many cases extend far longer than that in time. So first category of additional symptoms is re-experiencing. So that includes flashbacks, it includes nightmares at nighttime, it includes dissociative experiences where someone's lost in terms of their contact to the external world, but internally maybe re-experiencing something. Second category of symptoms they have to have for PTSD is avoidance. So either within their thoughts or avoiding or not going to areas associated with the trauma, or physically avoiding being in the same situation, being with the same types of people or the same types of threatening animals, environments, characters, individuals. So avoidance is the second category of symptoms for for PTSD. 3 is that there have to be negative cognitive or emotional sequelae from this. So it could be distortions about the event itself, imagining that it was different from how it originally played out. It can be pervasive fear, anger, negativity, self-blame, guilt, shame, social withdrawal because of how you feel about yourself or humanity because of the events. And the 4th region of symptoms someone has to have for PTSD is hyperarousal symptoms. So that can include a hyperactive startle reflex. It can include disruptions in concentration and sleep. It can include impulsivity, hyperactivity. So you need, again, symptoms from all those categories after, and all these symptoms have to arise after the traumatizing event. And although it depends on the survey and the cutoffs and the specific population looked at, something like 50 to 70% of American adults have experienced some trauma that would be severe enough to be considered a trigger for PTSD. Something lower than 10% by most studies have pervasive ongoing PTSD. So clearly the trauma alone is not itself sufficient. Although it's necessary for this diagnosis, it's not sufficient. And a lot of research has gone into studying why some people develop, with apparently similar exposure to trauma, different long-term trauma responses or lack of responses. And clearly there are some genetic factors that are involved. Our simplistic neuroscientific explanation right now is that the core of PTSD is both an exaggerated fear response, so it's an excessive amount of fear gets re-triggered by a number of different triggers, and there is impaired extinction or impaired poor learning at stamping out this exaggerated fear, and not just the fear reaction itself, but the number of different elements that can trigger it. So on the surface, there's clearly a lot of overlap between ADHD and PTSD. So both of them can include impaired concentration. They can both include impaired memory. Emotional dysregulation is common in both situations. Impulsivity is common in both. Restlessness is common in both. Disturbance of sleep is common in both. A higher likelihood of relying on drugs and getting into substance abuse problems is impaired in both. Impairment in social connections and interactions is there with both conditions, and an excessive amount of shame or preponderance shame can be in both conditions. With ADHD, it's often around being perceived as being different, being treated differently, being overly criticized, and often associated with that as being aware of some of that, but not even always being aware, partly because of the ADHD, as to what other people are objecting to or noticing that I'm not feeling or recognizing or seeing. The shame with PTSD is tied into the acknowledgement other people were experiencing the same trauma. Why am I so troubled or bothered by it? And particularly given that many of the groups prone to exposure to trauma, so military people, law enforcement people, are prone to have a more macho, I'm strong, I'm tough, I can get through anything, so any deviation from that is treated more as an article to be shameful about than it might be in a more general population, although there's plenty of shame to go around in the general population. So as I said, so again, if you have ADHD, so again, there's an association between these two. Clearly, there are many individuals with ADHD who don't have PTSD. There's many individuals with PTSD who don't have ADHD. And there's a little more research on how ADHD may contribute to PTSD. I mean, part of that is the basic framework that our understanding of ADHD is a pervasive developmental condition with a strong genetic influence that involves some neuroanatomical, neuroconnection, neurochemical differences that arises early in life and then is pervasive through many individuals' lifetimes. So one way that ADHD itself can be can contribute or trigger to PTSD is clearly repeated studies show that ADHD itself makes it much more likely that you suffer trauma. So if you behave more hyperactive, more impulsively, you don't look at the risks, you jump into situations, you're inattentive, you may be missing important salient clues to avoid injury, but a whole host of injuries and accidents, from emergency room visits to car accidents to suicide and death from that, are more common. If you have completed suicide, you are not going to develop PTSD after that, at least in this plane of existence, but again, more trauma clearly in the ADHD population, about twofold difference compared to people without ADHD. But on top of that, the studies, most studies, not absolutely all of them, but most studies have found that even controlling for the same amount of trauma, people with PTSD or people with ADHD are more likely to develop PTSD from experiencing their trauma. And there's two, sort of one generalized theory is that many people with ADHD have hyperactive sympathetic nervous system because they have been perceived as being different. They have been treated, criticized more routinely, more frequently. They have been bullied more often, and they may develop aspects of hyperarousal, hypervigilance, hyperscanning, which make them more susceptible when a trauma occurs to PTSD. There's also some really interesting, fairly recent work looking at children with ADHD who had not had any trauma, comparing those to non-traumatized children without ADHD. And the findings were suggestive that, and again, these are laboratory situations, studying ways, looking at paradigms for studying exposure to fear and how brains process or deal with that fear, and how they unlearn or cause extinction of the fear responses. And the kids with ADHD were less good at impairing or causing to go extinct their excessive fear reactions. And these were brain imaging studies that involved looking at differences in the ADHD groups. So the ADHD kids activated to a less extent their ventral medial prefrontal cortex, and the VMPFC is found to be an important part of the unlearning or the extinction process for fear experiences. And also during this, again, laboratory experiments, less activation of the hippocampus in the ADHD people, and the hippocampal activation seems important for pulling in context, for helping make that fear specific to a narrow context rather than a broader context. So again, some deficiencies in the ADHD group in that respect. So that's about all I'm going to say about ADHD contributing to PTSD. I'm going to look at the opposite situation, and that's PTSD contributing or forming either ADHD or an ADHD picture that looks just like ADHD. Again, by our formal DSM-5 definition, to have ADHD, you had to have some symptoms have to have been present before age 12, but clearly there are ADHD-like pictures that can develop in adults even who have had a traumatic experience. And the general explanation is that trauma can cause rewiring of the brain. What I'm going to bring in more when I'm talking about this is that there is a school of thought, and I would put it in the camp of people who are ADHD diminishers or denialists, and one of the most prominent people in this field is Gabor Mate. He's a Hungarian-Canadian physician who wrote the book Scattered almost 20 plus years ago. He's written other books, and his thesis is that ADHD is essentially caused by trauma in early childhood, and it's caused, and particularly poor paternal alignment with the child, and particularly poor mothering is a major contributor or is the source or cause of ADHD. And he writes well about trauma. He makes important connections. Much of what he writes people can relate to and identify aspects. But I'd say the general thesis that all ADHD is the source of PTSD, and some of the comments in his book clearly are that strong and forceful, are just flat out wrong. I mean, one, it completely denies the existence of a vast area of genetic research where we know that there's a strong genetic component in kids who will develop ADHD symptoms. Two, it sort of ignores the fact that, yes, many kids, because of this genetic influence, are living in households that are more chaotic, maybe less connection or good connection between, or alignment between where the kid is at the moment and the parent at the moment. But very clearly, even I mean, there are many kids growing up without ADHD parents who have ADHD, and in many individuals' lives, even very careful scrutiny, finds an absence of any trauma. So if you have an absence of trauma and yet trauma is the source of it, that doesn't quite make any sense. And again, the timing, again, from all the studies we have, ADHD is developing at a very early age of brain development, and you can pick up symptoms and aspects of it from an early age, and most of the time classic PTSD is develops at an older age after a specific event. So I'm not going to say too much more about that, just that I think any honest reading of the vast body of literature out there, scientific research, would not support that PTSD is the major contributor to ADHD. So what do we do about this overlap between conditions? So I'd say it's important to know what you're dealing with if you're trying to help an individual. So again, even though there's a big overlap in these symptoms, part of careful evaluation involves the timing of when did these symptoms arrive, or did they all show up after significant trauma? Were they pre-existing? Were they pre-existing to different extents? Two, are they pervasive in a realm of areas? Or often with PTSD, there's a narrow range of triggering stimuli, and that when someone's in other environments or other contexts, they are largely free of their PTSD symptoms. And one of the things that I think there's a trend in our mental health clinical practice, partly driven by insurance companies, partly driven by our whole culture that wants to put numbers on everything, maybe to make it easier to monetize it and sell it, but part of it's more the broader digital revolution, thinking if we can code everything, then we can solve everything properly. So this increasing reliance on symptom checklists as a way of capturing what has gone on in an individual's life, I think there's some value to it. I think there's some value to being rigorous and thorough and having somewhat objective measures. But when we rely and focus excessively on just the symptom checklist, does the person have a sleep disturbance? Yes or no? What you may be missing is the person's having trouble falling asleep because their thoughts are bouncing all around. Well, are their thoughts bouncing all around? Are those fearful thoughts, as would generally be the case if it's PTSD or associations with a traumatic memory? Or, and again, you can have fearful thoughts in ADHD even in the absence of PTSD, but in ADHD, at least some of the thought bouncing around is just neural, random, not particularly negatively, fearfully connected. And just again, a simple checklist approach makes it much harder to sort out what may be going on, or help us. It may impair our ability to differentiate, actually, PTSD from ADHD. So, and again, both can certainly be co-occurring in the same individual. Again, they do that more likely than they would just by random chance. What can we do when we have both going on? So one thing to be particularly wary of, the standard, most effective treatment for ADHD continues to be the stimulant medication. And stimulant medications are among the most potent triggers for PTSD symptoms. That doesn't mean absolutely everyone with PTSD has PTSD worsened by stimulants, but there's a high likelihood of doing so. Again, it's feeding into that sympathetic nervous system over-arousal state. So use of stimulants should be done very cautiously in this context of PTSD. And at least on the medication front, some of the medication, one is we do not have any medication that is clearly robustly helpful for the broad range of ADHD or PTSD symptoms. So again, we don't have a good simple medication for PTSD. Some people do benefit from SSRIs. It's sort of dampening down some of their hyperarousal state. Traditionally, SSRIs are not particularly effective for any of the pure ADHD traits, but they may be, again, useful in this conjoined situation. There's one recent study, not fully printed yet, looking at atomoxetine, which is Strattera, and finding efficacy for both PTSD and ADHD symptoms in the context of individuals who have both of those. And if we jump back to one of the talks a few weeks ago on guanfacine, even though one study 15 years ago failed to find any benefit for, again, this is looking, so guanfacine clearly can help people with guanfacine clearly FDA approved for treatment of ADHD, clearly can help with direct focus, concentration, distractibility, cognitive aspects of ADHD, also can help with emotional volatility, hyperarousal overdrive, restlessness, other aspects of ADHD. One study, large study 15 years ago, failed to find any benefit of guanfacine for PTSD, but there have been some smaller subsequent studies with apparent good results and improvement in a range of subsets of PTSD symptoms from guanfacine, and some of the suggestion may be that actually lower doses of guanfacine for treating may be appropriate for treating PTSD than for treating ADHD. And maybe the big study done, again, a decade and a half ago was looking at too robust a dose and overtreated people and therefore missed its ability to help with PTSD. So beyond medication, for years the standard, most effective approach for PTSD has been exposure therapy, talking about going over, reliving the experience and learning to put that in a different emotional, cognitive context. And again, that helps better than anything else in our formal studies of PTSD, but something up to 2/3 of people either can't tolerate or don't want to tolerate it. So we have a big need for other approaches. There's been a lot of research as well on somatic therapies, which focus on the body and training the body's stress trauma response. So without reliving, re-experiencing the trauma itself, and reactivating that, it's teaching people to be more aware of what's going on with their body, and teaching not just awareness and how it feels, but how to send information back to those body parts so they can relax, so the whole body and system can relax. There's certainly been some amount of research and many individuals who've had substantial success from EMDR, which I would say I would situate, and people may feel differently, somewhere between the exposure and the somatic approaches. And we don't know what are the crucial elements for effective EMDR, but that's eye movement desensitization training. So that involves reliving the experience. So it's a form of exposure and retraining the body. There's also, and I've talked about this in a previous talk, some interesting research. It's only been one or two small studies looking at just teaching people a mantra and teaching them, again, it's a way of teaching the body a different way to deal with a stress response than to go into sympathetic overdrive. But a simple mantra in at least one study, was as effective for a broad range of PTSD symptoms as exposure therapy as the gold standard. So that's what I'm going to say today about PTSD and ADHD. I am not seeing any questions coming in yet. I will be back next week to talk about cultivating ambivalence. Should I do that? Should I not? Find out. Be back next week. So stay healthy, stay happy, and have a happy Valentine's Day.